It's great to finally meet. I heard great things about you.
Well, I don't know if I deserve them, but I think at 11:30 p.m. I got a second offer from a competitor to Novo, and actually the terms were not very different. A few years later, Novo is one of the dominant market cap in the world. It's been a great deal for us.
Was it already your plan to go in, exit pretty early?
Maybe I'm not smart enough to do the other way around.
Hi, I'm your host Philip, and welcome to a new episode of the Flot.bio show, where I interview the best Europeans in biotech to help you grow. Today, I'm back in Paris, quite sunny and nice, to talk with Marc de Garidel, who is the new CEO of Abivax. Marc is one of these biopharma veteran with an impressive track record. He made $2 billion exits. He was the CEO of French Pharma Ipsen, and now made the biggest IPO ever for a French biotech on the Nasdaq with Abivax. Actually, I don't know him personally, but I've heard great things about him, both on the track record side, but also on the personal side. So I'm very excited to meet with him, and we will talk about actually what were the challenges behind the exits, as well as why Abivax could be a next big success. So let's head to the office and meet with him. Welcome to the show, Marc.
Thank you very much for having me.
It's great to finally meet. I heard great things about you.
I don't know if I deserve them, but it's good to be here. So.
Let's see. Actually, for today, I want to start with the two exits you did prior to Abivax. I mean, both were in the billion biobucks / billions. I mean, Corvidia, I think, was $75 million upfront dollars. CinCor was 1.8 billion. That was in cash, which is impressive. Actually, I don't know many people who did two exits like this. But I've also heard that it was not a smooth ride. So could you elaborate a bit more on what happened and what didn't make it a smooth ride?
Well, as you know, biotech is always a bit of a lively experience. So I think in the case of Corvidia, the challenge was that we are developing an anti-inflammatory treatment for arteriosclerosis. And we had been actually in discussion with one of the big pharma fairly early on when I joined. But what they wanted to see was actually the phase 2 completion before possibly doing a deal. The challenge also of the program was related to the fact that the phase 2 was relatively simple to execute. It was a 250 patient trial. But the phase 3 would be more like 3,000 to 5,000 patients with costs probably ranging from $300 to $400 million for the phase 3. So it was clear from a Corvidia standpoint that the step from phase 2 to phase 3 would be a difficult process. And we were preparing actually for an IPO in that context. So we actually ran a sort of a dual approach. One was indeed execution of the phase 2 and seeing whether a partnership could be possible, and still in parallel trying to raise money for the phase 3 in case a partnership would not happen. So I think what was very interesting is we got actually a first offer from a big pharma company. Again, maybe
not from Novo, from
another one who came about, and the first proposal was we thought was very low. So we told them, we cannot accept. We keep going with our phase 2. But as the phase 2 started to get toward the end, then we had a very productive discussion, actually starting at Jefferies, which was in November, preceding basically the deal. And Novo started to show real interest into possibly looking at our phase 2 data and possibly doing a partnership. So we at JP Morgan organized a more thorough meeting with basically all the research team and R&D team actually of Novo and ourselves to try to come to a potential agreement on conditions for a deal. So Novo followed that procedure and essentially gave us a term sheet in March of that year.
It was quick.
It was but this was upon the condition of success in the phase 2, which again could be always argumented and challenged. So we so we are on one hand very happy, but we had still to wait for the result of the phase 2. And then when the phase 2 results were uncovered, we are obviously very happy with the results, and we communicated that to Novo. But that, in the meantime, so I gave a call to the other party, saying, now we have some great results. Let's say, are you still interested, or would you consider, doing a partnership with us? Because we have already a term sheet from a great partner. And I remember vividly because I was actually in my house. This was COVID time, so this was when everything was virtual. I was at my home in near Boston, and I got this call from the head of R&D from this big pharma, whom I knew actually from history, who told me, no, Marc, we are very interested in possibly doing a deal with you, but give us a bit of time because we need to analyze your phase 2 under confidentiality. But we come back by Friday midnight of that week.
Okay.
So
which months are we talking about?
We are probably at the end of we are in June. June of 2020. So then that Friday, at maybe 4:00 in the afternoon, I called the head of BD at that company, and I said, I haven't heard anything from you. Are you going to submit anything? Or because otherwise, the other party is ready to sign. So, this business officer says, we are preparing something, but give us a bit of time. We know midnight is the deadline. So I think at 11:30 p.m.
Eastern time or your
time, I got the second bid from second offer from a competitor to Novo, and actually the terms were not very different. So I sent immediately a message to the board. I had given them obviously the heads up that things were cooking, but I was not sure.
Yeah.
And then I told them we need to probably organize a board meeting tomorrow to review the two bids and see what you want to do. But I think I would propose we take a bank to help us through the process. So to cut a long story short, we put in place a bidding system. So the bank organized. So by the following Tuesday, we would have essentially competing bids, and the best offer would win. And what was very interesting is the big pharma who thought they would win actually lost to Novo, who actually overbid, and the increase within 2 or 3 days. The terms changed substantially. So it was wonderful for obviously for shareholders. So shareholders was wonderful for us, and I think ultimately now Novo is developing. I think I believe they are doing 3 phase 3s for the drug. And hopefully in the next couple of years, we're going to know whether this drug is going to be a bigger drug for reducing inflammation and arteriosclerosis in patients.
I mean, I heard also, I think it was one of the biggest deals of Novo around that period, or even not ever, but in these years around, they didn't make that many big deals.
That's right. Yeah, it was the first actually. I think it was.
And they lost Abivax. I think Abivax, they lost it to Sanofi.
Yeah, exactly. Exactly. So for Novo, it was a big step forward. And I remember the discussion with Lars, the CEO of Novo, who's actually a great CEO. And he told me, yes, this would be already a big step for them. So obviously, a few years later, Novo is one of the dominant market cap in the world with their drug. But it's been a great deal for us.
No, it's nice. On this outbidding, it reminds me another story, which I forgot the name of the biotech, but it was, I think, last year where they was outbidding 2-3 times, and it went up to like $1 billion when the first offer was like 5 or 6 times lower.
Yeah.
I mean,
in our case, we said on Tuesday, you need to have your bid by noon. We'll have a board meeting at 1. At 2 o'clock, we'll let you know who was win and who was lost.
That's pretty quick. That's a quick time. But I'm wondering more on the lessons learned, and for you, I mean, as running a biotech, I don't really understand why you wouldn't do such a process or try to get, I guess, what's the limiting factors if you have not enough interest from pharma? Or what would be the...
No, I think part of the challenge was, in order to finance phase 3, that is going to cost, 300 to 500 million. There are not so many pharmas at the time who would have been interested. And by the way, cardiovascular, you remember, was kind of ignored starting in the mid 2010 period because of exactly these studies that are very big, and you need to do an outcome study, so you need to demonstrate that you're really literally saving lives. And a number of pharmas like Roche and Novartis, just to name a few, had spent up to $700 million in studies, and then everything passed because the results were not good. So I think already Corvidia was one of the first, certainly one of the most surprising deal at the time. One, it was because it was COVID, everything was kind of dead, and two, it was in a therapeutic area where no one would have expected a deal.
Yes, that's amazing. And I guess from what you just said, also on the running phase 3, there's also a good chance that the milestones would be paid, because I think
we hope so.
75 up front, but then there was 1 point.
Well, there is another 1.4 billion in milestone, 700 million related to basically registration of the drug, and then there are milestones on sales.
We'll see. Fingers crossed on that. And I would then also, cardiovascular already was, as you said, from big pharma, dropped it or less interest, but especially as a biotech, very few biotechs going there, also from the size of the trial and the money you need to raise. But you basically with CinCor was also in the cardiovascular space. So, and it worked also pretty well. So.
Yeah, because I think, at the end of the day, almost regardless of the therapeutic areas, what you have to try to find is our drugs which can, bring a therapeutic value to patients. And because a lot of companies were in oncology, everyone tend to flock to the same areas. Actually, in cardiovascular, there was not so many assets, but there were still a few good assets. And the CinCor asset was actually a drug that was initially at Roche. Roche decided to get out of cardiovascular, but they had done all the really very good quality experiments in preclinical setting. And what happened is, an incubator basically negotiated with the help of Sofinnova Investments and Sofinnova Partners the extraction of the drug out of Roche to start developing it, in human clinical trials. But all the foundation of the work was done, was first-class work from Roche. So for me, when I was contacted again by Sofinnova to be part of this new adventure, I was very reassured that the foundation was very solid. The early preclinical work was first class, and also the positioning of the drug was going to be very differentiated from anything that had been, in existence to treat those hard to treat resistant hypertension patients.
Yeah, what does so then you joined, and then what? Can you go through what happened? This was even faster than Corvidia.
It was faster, but it was also a fairly lively experience, because a few months into the job, first we got a lawsuit from the incubator, who was in Cincinnati, because we had transferred some of the employees in the incubator into CinCor, which by the way was part of the program. Everybody had agreed to. But there was some question about compensation and things like that, stock options. So we already ran into a lawsuit from with the incubator, was also part of our shareholder basis. So, and in the meantime, I needed to raise funding, to accelerate and to conduct 4 phase 2s pretty much in parallel. So the good news is we were able to raise, summer of 2021, about 190 million in a Series B. That was the first big basis, and then we wanted to do an IPO by the end of the year or early in 2022. And then, as you know, 2021 was the year where things started to shake up, especially in the second half of 21, where it became unclear as to whether we could do an IPO. And then we had this lawsuit. So we eventually, the good story is that we were able to resolve the lawsuit. And then we were able to be out, do the first IPO of 2022. We are the first one listed on the NASDAQ. And actually, we did very well because I think everybody was excited about our program. And again, we raised another 200 million through that process. A few months passed. We have the first result of our study in this hard to treat.
Was already the phase 2 results.
A few months later. Yeah. And on that basis, it was really successful. And as a result, we were able to do another follow-on. We raised another 200 plus. So we basically raised 600 million within a year, which was, again, one of the highest in the world in that period. And while we were doing this, AstraZeneca was actually watching us because they thought, again, this mechanism of action. So it's basically inhibiting a very key hormone that plays a role in hypertension. And they were very interested in this mechanism of action, possibly combine it with their SGLT2 for CKD patients. Okay. So, that discussion with AstraZeneca took almost a year to complete before they made an offer. But then, life in the biotech, as I said, is never easy. The second phase 2 study that we were doing in a less severe population actually was a disaster. Okay. So everything, basically the results were poor, not because the drug didn't work, but essentially the patients we enrolled and the centers that were used, even though they were the same center in the hard-to-treat population, there was a lack of compliance in the study. So basically, the criteria for inclusion were not very well respected by the centers, and we had a huge placebo effect. So actually, this was, I think, one of the worst studies ever seen with a placebo effect of 16 millimeter for mercury. We've never seen that before in any study. So it was an entire disaster. So crazy how. Okay. But the good news was because we had taken blood samples of the patient at baseline and at the end of the study, we were able to demonstrate over time that again it had nothing to do with the drug. It was really poor execution of the trial by the centers, and that actually nothing went wrong. And by the way, we shared it with the FDA. The FDA at the end of the phase 2 meeting did recognize the same thing, and AstraZeneca was able to complete the transaction.
It must be really hard also to frame the story or even explain. I mean, usually the phase 2 results are kind of the headlines or like studies, and then it's like arguing, and every biotech when there's a failed or a low result, they try to argue, but at least from my experience, it's never that clear that it's like.
No, sure. I mean, when we announced the result, the stock went down by nearly 50%. Yeah. But again, because we are a very good scientific team, we are also by great opinion leaders. Because we had such amazing results in this hard-to-treat population, everybody knew it was not making sense. It would not work in a less severe population, right? Because if it works for a very young population, it can't.
Yeah.
And it had something to do with the design of the study or the way it was conducted. So anyway, just to say, yeah, we went from going up, then we crashed, and then we came back, and then AstraZeneca bought us, and in the context of competition, because there was another company that was that would have been interested probably to get bought. But we, in the end,
did you do also outbidding process there?
So we had some discussion with a few companies, but I think some of them were a bit, shaken by the early population results, so they decided to pass.
Okay, but. I'm curious about this on the compliance and how run the clinical trial. What were your lessons there? What would you, let's say, do differently next time?
Yeah, well, I think what you learn is that, which by the way applies to Abivax, I said to the team here, is the discipline of conducting a trial is extremely important. You have to. There is a balance between quality and speed, right? And the danger that we all have in this industry is because of money reasons and the time it takes to develop drugs is to go very fast.
Yes.
And when you want to go very fast, you go to centers who's they are not cheating on purpose. That's not what we're saying. But their standards may not be as high as you want, or what the doctors do is that they don't, pay the same level of attention when they, recruit the patients in terms of the criteria. And, so the lesson for us, certainly for Abivax, is we have to work on the placebo effect in these studies. Yeah. And part of it is having MSLs to help train the centers so that they target the right type of patients, and to do sometimes audits of these centers extensively, so that again those centers are not enrolled if they don't if their discipline is not as high as we would like to be.
And you do that, or even the audits internally, or then it's also, I guess you're working with the CRO.
Yeah, so usually it's the CRO who does that for you.
Yeah.
Or you can independently, depending upon some companies do it independently, but the CRO can do that.
I guess also you are very also careful in choosing your CRO, even like supervising and working.
Yeah, sure. Yeah. And probably to me the second lesson which we have applied actually at Abivax is we had a limited number of oversight at CinCor, so we are fairly relying on the CRO, was a good quality CRO, but nevertheless, we probably
trusted too much.
Yeah.
And I guess with any kind of service providers, the way you manage the service provider makes also a huge difference.
Yeah, but yes, but that I think we had the relationship with the steering committee. We reviewed a number of things, but. I think still the key to me is you need when you are a small biotech company, when you have been used to an outsourced model, you still need to make sure you have core competencies and some people you hire who have skin in the game, who are on your side, to review what the CRO is doing and the centers.
Makes sense. That's good. So taking a step back to what you mentioned on doing IPO on CinCor at the period where you were one of the first or the only one of the year, and now you did again with switching to Abivax, especially one of the only one this year, at least in this size, and I think was the biggest one of a French biotech ever on the Nasdaq. Even I compiled data, I think in the last 5 years at least, must be the top 5 in Europe even, which is really impressive as well. How did you manage this when it's how did you manage it when in both cases, the market was just not favorable, and you still managed to push through it. I mean,
well, obviously, I mean, there are a number of factors that play. I think part of the success was already ingrained in the fact that in February of this year, the company had done a crossover round, attracting some top-notch crossover funds. So I think there was a foundation of investors, deep pocket investors, US investors, who knew well, the story, and were going to help back the IPO story. But I think part of the reason we were successful is that, we brought also a team on top of the existing team. We did a great job for phase 2. We brought much more US experience in the management team quickly. We did a strategic review within 2 months. We laid out a plan, which is not, a 6 months plan, but really the 7-year plan in terms of how we could exploit the potential of befazimod, which is, a very, very attractive drug potentially because it's an oral treatment. It's an immunomodulator, so it's not like blocking one pathway for specific reasons. So it helps probably reduce the risk of safety adverse events issues, which we have seen, by the way, in phase 2, where so far the profile has been very good. So that strategy with a great drug, a great potential drug like this, was, I think, became a bit clearer to the financial community. And then we were helped also by the fact that we released 2-year data on the drug that was, I think, again, it's not head-to-head study, but this is the best ever seen in ulcerative colitis. So I think the conjunction of, having already some key investors up front, to have a management team that I think, had the credibility in terms of strategy, but also execution with some of the arena people who came in, plus the phase 2 data, 2-year data, which was really best in class combination. The key elements were there for a successful IPO. Then the market obviously was not good, and actually got worse and worse because obviously not only inflation, not only the Ukraine war, and then what happened in Gaza and Israel. So we're certainly lucky to go through this IPO, but the conditions here were not the best, and the price was not initially. We had a reaction, negative reaction
after the listing,
but now we're essentially back to the price of the IPO. So again, you go through this tribulation, but fundamentally, what was important is to get the money to execute the phase 3 program in ulcerative colitis, to do the phase 2 in Crohn's disease, and potentially develop a follow-on product, for the long term.
Yeah, that's. I want to go back to the pivot was Sofinnova coming in, and you coming in, because in the IPO, I think you raised a bit over 200 million, but before you raised, what was it from? The Sofinnova invested, I think, was 150, and then debt on top. So in total was 500 million, if I'm correct on the numbers.
Yeah, so what we raised this year is 130 million euros in February. We did a debt facility in August for 150, and then we raised about 200 million euros net in the IPO. So we raised altogether about 500 million, which, by the way, is in the top 5 in the world of biotech this year.
Yes,
and certainly the largest amount. Not in France, but
in Europe.
Within a year.
Yeah. Can you go back to the story? I think I heard that Sofinnova played really a pivotal role in kind of I don't know if you call it a relaunch, a reboot, or let's say a pivot. Can you go a bit specifically of what happened, how they contacted you, or everything fitted there?
Sure. So again, if you go back a year ago, company again was planning to be sold after the phase 2. Unfortunately, it didn't get sold. And as a result, it had still announced that it was moving to phase 3 with a large potential commitment of probably 200 to 300 million euros. Yeah. So the company got into a severe situation where it had a good drug, but it was not well financed. So Sofinnova partners played a key role.
They were a bit stuck, I guess. They couldn't start the phase 3 the same time.
Exactly. So they delayed a bit the phase 3 as a result because they thought, this is a good drug, so someone will show up. And, in the end, nobody showed up. So part of the key roles that Sofinnova partners played already a year ago was they said, okay, we need to reshape the way we operate. We need to change the chairman. We need to have a chairman who has probably more experience in the phase 3 development program. And also, because of the sheer scale up, again, the complexities, we need to change the CEO to address the complexity of a large program. And someone who can also help raise a large amount of money. So that's where Sofinnova came in essentially September, October of last year.
And they were shareholder before.
Well, yeah. So my story was a bit funny because when I got out of CinCor, I announced the deal at GPM, and I said I'm dead, I'm finished, I want to retire, so I want to go back to Europe because I was based in Boston before. I want to retire, But Sofinnova partners came back and said, Marc, can we do a bit of an exception?
One more.
I said, no, not one more. I said, okay, could you be a chairman of one of our companies?
Okay.
So I said, well, being a chairman is obviously a different story. So that maybe we have obviously a great history together. Why not? So I asked, Antoine, can you tell me, what are your 2 top picks in your portfolio? Because I don't want to do the work. But please tell me what are the best companies in your portfolio where you are looking for a chance. So Abivax was one of the 2. And as I got into, then the discussion with Genmab, who was on the board of Abivax, I was more and more attracted by, the science, by what had been done, by, this sort of turnaround that needed to be done. And my conclusion, which I expressed to Genmab, was, at the end, I think, you'd be better off having me as CEO than a chairman, because, there is very little time for this company for a turnaround, given the fact that, the fact it's not well financed. Phase 3 has started, but it's not really going fast enough. So you need someone to execute, to execute, and I'm willing to do that. Okay. So I changed my mind, and
so you sold yourself to do it again.
Exactly. But I have no regret. So it's it's a great undertaking. We can possibly change the fate of patients in the long term in this ulcerative colitis setting. This is very, very unique. Now, there are always risks when you do clinical development, and but it's a wonderful opportunity.
It's an amazing story, and I'm quite impressed by how quickly you executed also since joining. I mean, raising these kind of rounds of even changing or hiring more some more US based C-levels. I mean, seems like you went very fast.
Yes.
How did you manage to go that fast?
Oh, I think it's when you have experience, the tempo. I think if you look back at CinCor was already managed in a very at least overall efficient way. So once you've done the analysis of what is the challenge of the company, the biotech, then it's more are you convince the board on one hand to get the resources you need, and 2, to put the process in place so that you get the money you need to execute, which was the IPO, and then put in place a team that will be ultimately responsible. And I think where also I got some help is that Sofinnova and the board attracted in the spring, so in March, Sheldon Sloan, who was the person who ran the ARENA studies, the UC study at ARENA, which ultimately got bought by Pfizer. So Sheldon had a great understanding of how to run a large phase 3 ulcerative colitis program. So and we both
independently or
independently, he came before me, even though I was part of the process indirectly of because I was being considered as a chairman, so they asked me to speak with him, even though he didn't know that I was going to be ultimately the CEO. He thought I was going to be the chairman, but so it was part of this process. But the fact that we had people we knew, and then we attracted a bunch of people very quickly. So we didn't need to go through headhunters and all the gyration of normal recruiting, because we knew people in the field who could be able to execute such a complex trial.
That's good. I guess it helps to, as you said, to have gone through it, and I guess massive network as well.
Yes, exactly. It helps from.
That's great. For the clinical results, I'm curious on if we can go a bit more into the science and / the clinics. How, because in UC or even in IBD, there's still, at least in IBD, there's quite a lot of drugs also around. Can you go a bit on how good were the phase 2, how it compares to the standard of care, or what's in development?
Sure. So I think again, first to help a bit understand the setting. So when you have ulcerative colitis, the symptoms you have as a patient, you have rectal bleeding. You go very frequently, you need to go to the bathroom very often, including at night. And then gastroenterologists who treat you ask you to do, sort of a coloscopy to check whether the lining of the stroma of your intestine is being altered by, many ulcers or not. So from that sort of conjunction of looking at those three elements, there is a score that is being, sort of used by the gastroenterologist to assess the severity of your disease. So, and this is a population again for mostly people are diagnosed between 20 and 40 years old. So it affects a really young population. So what happens is, for the treatment, usually what happens, you get 5 ASA, so that's sort of an old, generic compound that start to stabilize your disease for a little while. But very often, after a few months or maybe a year or two, disease continues to progress, and then the doctors start to put you on corticosteroids. Corticosteroids, they are again good to against the flare-up. So when you have a peak of inflammation, however, if you prescribe corticosteroids in the long term, they can affect the
massive side effects, systemic side effects.
Yeah, systemic, like diabetes and increases the risk of death and so on. So doctors really want an alternative. So before we talk about obefazimod, until now, what happened was mostly you had what they call advanced treatments or biotherapies, which were the anti-TNF. The anti-IL-23. The Rinvox or the JAK ones. All those drugs have their utilities, but they face a few challenges. One is some of them have black box safety warnings, because they have some serious, adverse events in terms of either affecting the human system and therefore being more prone to infections or cardiac problems. Some of them have more recently who have arrived, like the S1P, the ozanimod from BMS, which is the first real potential oral treatment before Rinvoq, as pre-initiation requirements. So you need to do ocular exam because you have the risk of loss of vision up to 30%. So essentially you have a lot of drugs out there. Some are highly effective for a while, but then over time, either their efficacy starts to wane, or two, the side effects, the adverse events start to show up and they are really problematic, which forces doctors to change treatment for patients. So, obefazimod, given the phase 2 results we have seen, is ideally placed now as what we call a first-line or advanced therapy agent. Why? Because we think we could be well placed after, again, 5-ASAs and corticosteroids, but before all these advanced therapies would generate their own set of challenges. And the profile of obefazimod is such that when you look at the phase 2 result, is that first, after 8 weeks, it has a competitive response for patients. It's really in the landscape of all the other drugs. But then over time, after 1 year, 2 years, you see this lasting efficacy that we don't see with many of the other.
The 3 years data.
3 years data. Yeah, you have if you take the patients who were enrolled at the beginning of the study, 2 years later, regardless of the profile of those patients, 50% of them are still controlled. If you take now the patients who responded after 8 weeks, so 2/3 of these patients are controlled after 2 years. I mean, no one, again, it's not we cannot claim superiority because we don't have head-to-head. But in absolute terms of any published studies, we have the best response. And this is what was presented at the recent congress at UEGW, which is basically the Gastro Week for Europe in Copenhagen, where we were, in the session New Kids on the Block, so basically new product. And our data was judged as, the best abstract because simply, it is the best data out there. So that's why I think obefazimod has a very important role to play. And to finish just on the safety front, because doctors are, this is a chronic condition, doctors are obviously very worried about the safety of their patient. Yeah. So what we have seen is we have treated more than 1,000 patients now, and we haven't seen any opportunistic infections. So we have not seen cancer, which could be certainly a risk when you depress the immune system. Nothing of this nature so far. And that's more than 1,000 patients. So again, that could be. So we think again, this drug could be very important for the doctors.
I'm curious about UC and IBD. I mean, it's very tied to the microbiome.
Yes,
deep down. So how does it connect, let's say, to microbiome or even to microbiome drugs or even lifestyle biotherapeutics? I mean, more from a alternative way to treat it.
Yeah, so it's a new mechanism of action. So what it does, it upregulates. So obefazimod in itself upregulates a key molecule which is called miR-124.
It's a microRNA.
Yeah, 124. And it's very specific to immune cells. So what microRNA 124 does is essentially, we've proven that in our preclinical experiments, is if you take a mice whose immunity is okay, so who has no IBD, you'll see you administer obefazimod, you see no impact on the cells of those mice. When you take a mice who has the ulcerative colitis, so it's called the DSS model. What you see when you administer obefazimod, you see the production of microRNA, accelerating and basically regulating, different pathways, so that essentially the inflammation that is caused by ulcerative colitis, this is tempered by microRNA. So microRNA 124 is essentially a regulator of the inflammation process. And what's wonderful, it doesn't block, everything.
Yeah.
It's just controls it, and it's pleiotropic in the sense that it's a physiological reduction of inflammation throughout, for example, the IL-17 pathway, the IL-23, and the macrophages, for example. So it's a more subtle, I would say, way to reduce inflammation than boom, you just attack one pathway, which is great in the short term, but because of the body, you're redundant. Then ultimately the body finds a way to lose inflammation through another pathway.
And I guess that explains. I mean, this more subtle way, and
yes,
explains also why it lasts longer and the safety profile.
Exactly.
But still on the cause, because at the end, the cause is still more microbiome.
Yeah, we are not
fixing the cause. You're fixing the symptoms and make it.
We are controlling the disease. We are not addressing, fundamentally the origin.
And
which, by the way,
it makes sense to address. I mean, not for you specifically, but let's say in the current development to actually address it directly?
Yeah, I mean, there's been a lot of companies who have tried. It's extremely difficult because, the understanding of IBD, especially, let's say, if we take psoriatic crisis, it's based upon probably a conjunction of things. One, it could be genetics, so it could be some mutation, possibly. Two, could be hormonal too, if a disorder in hormones could also accelerate. And three, it's also the lifestyle. But when you eat, things that are preconditioned with a lot of, bad things, that ultimately accelerates the inflammation of your body and your intestine, and then creates this. So the science behind IBD sources is still underway. There's a lot of work to be done in order to really fully address what you are.
Because I think, at least from my understanding, a lot of microbiome companies are going in IBD, but have not really managed.
Well, microbiome is extremely complex, right? Yeah. Because you have billions of bugs that are have their utilities. Which one are the ones that you want to are fighting and so on. Yeah,
it's a very recent
field, and unfortunately, until now, it has not been really highly successful.
I like this. Okay, I like the complementary of there's some microbiome therapeutics that can fix the cause, but it's like it's a longer term horizon. Yes. But at the same time, we need also even more small molecules in first line that can be taken easily. For a long time, that's because that's one thing I was also wondering. Even if we zoom out a bit, Corvidia, CinCor, and Abivax are all small molecules.
Yeah. No, Corvidia was injectable.
Injectable. Yeah. I was wondering what's your feeling there if you just look from let's say small molecules versus biologicals versus or like more complex cell gene therapy. How do you see it? Like, what's your...
I mean, different modalities have their own values. So it depends upon the disease, what you want to do. So I don't think one should say it's one versus the other. I think it depends on the circumstances of the disease and what you're trying to address. But one thing we forgot to mention is, for example, for the future of IBD is a combination therapy. So a bit like in oncology where, when you basically combine different mechanisms of action to essentially to find a better solution for patients. So we believe, based also on the feedback of our key opinion leaders around the world, they told us obefazimod with this sort of unique mechanism of action could lend itself with other products that are out there, and they can complement each other, maybe by doing some of these highly effective drug. Maybe their dose could be reduced. You could add obefazimod on top, or you could start with one of these drugs and they put in maintenance. So there could be a variety of combination that could be very helpful to patients. So this is one thing that we are going to start actually preclinical experiments right now, and hopefully we'll have results of those combinations in the course of 2024 by the end of 24, so that in 25. Once we have the induction data, hopefully, very positive data, we can start doing combo work as well.
That's. I mean, I like your approach of not necessarily opposing small molecules versus modality, because I feel also, I mean, quite a lot of biotechs, I guess maybe because they come from the science, they're very focused on their platform, on their like modality, and will compare it to the rest. When I think at the end of the day, what tends to matter more is, okay, what are your
data? And what are you solving for? Yeah, sure. Yeah. I think the challenge, for example, with cell therapy and gene therapy cell therapy is more the production. This process and manufacturing is extremely difficult to do, and the time it takes to do that for those patients in the context of some of the acute disease. And then gene therapy, I think the next challenge is, as you know, has been, what is, everybody thought, you do one injection, you're done, you're fixed for the rest of your life. Well, it turns out that it's not that simple. Unfortunately, it seems also to have a waning effect over time. That's one. And two, you have the safety side of what is the support of which virus, or what is the platform of your gene therapy
platform.
Yeah, so that when it is administered to patients, you don't also create some adverse events that are not welcome. So yeah, I mean, again, science is always in evolution, so you need to learn and need to be open about different avenues.
Yeah, that's it. On the just question about on the market of where's the market, very connected to Abivax, but also a bit more of a general question. I think if I remember that in one of the press mentioned that 70% of the market for Abivax is in the US.
Yes.
And I feel I mean, is it because there's more patient there or it's more just from a market opportunity, from a reimbursement policy?
Yeah. So in the US, for example, if I give you some numbers, in the US there are about 800,000 patients who have ulcerative colitis.
Yes.
When we look at the population we can address, we think we can address about 25% of those.
Yeah.
Because they would be either ready once they have finished their first conventional therapy treatment, or we could get switched from current advanced therapy treatment where they fail or there are too much side effects. So that's about 200,000. In the US, just to give you an idea, the price of treatment, the net price after rebate to the PBMs, is about $50,000 per year per patient. So so if you multiply what we think is a potential, the addressable population for us out of the 800,000, we think we could have about 25%. So 200,000 patients times per year, 50 times 50,000. That's a 10 billion market opportunity.
Yeah.
So that's why we think, again, provided we can show again in phase 3 what we've seen in phase 2, this is a 10 billion market opportunity. So we are not going to get to see all the market, but 10%, it's already $1 billion, and this is only ulcerative colitis. The market in Europe in terms of patients is actually slightly higher, but as you know, the challenge in Europe, our prices have been going down and down and down. And governments are reluctant to pay, SG for big innovation. So, the US is 70% of the market.
So if it's 10 billion, so what is it in Europe would be 2-3 billion potential market?
Yeah, the Europe is about 20%
of the US. Yeah. And what do you think about this from if you reflect? I mean, you mentioned already that it's hard in Europe for let's say for biotechs to get the innovation finance. How do you reflect on this? I mean, I think for me, what I see is, I mean, that's kind of a fact, but I think makes it very challenging for European biotechs to actually, let's say, access the market, or forces them to go after the US market, which is not necessarily that easy from a talent, location, access to capital.
Yes.
So what's your what do you think about the situation?
Well, I think so if you are a biotech in Europe and you have a good drug, you can start indeed the experiments in Europe, but quickly you need to take a look at the US market.
Yeah.
And because this is where, in general, most of the opportunity is going to be. And also, this is where most of the sophisticated investors and deep pocket investors are. So it means that for the management of biotech, the need to have CEOs and management team with Europe/US experience is becoming more and more important. Otherwise, what would happen is, if you can do that, and what you have to do as a biotech in Europe, you have to partner quickly with a big pharma company that is going to do the job for you in the US and will do it obviously very well. But obviously the value creation is very different if you do a partnership very early as a small biotech versus later when you get the benefits of having produced good results and having partly address again the challenge of the US market.
I'm thinking maybe also from a policy point of view. I mean, talk in Europe or even in France about financing innovation a lot, and more on the financing side, a lot in the early stage side. But if the market is not there,
the irony.
Hindrance.
I mean, I was recently the minister doing a speech the Ministry of Finance here in France, I think 3 weeks ago. But part of the irony is that Europe helps, the foundation of the small biotechs. At the early stage, I think there is really good process, good help, and there are, good investors. The challenge is, as soon as you go into more intense, clinical trials, funding requirements, and so on, then, unfortunately, because there is less money available in Europe, you need to go to the US. And then, because of the cost of doing those trials, the return that are expected by investors are such that today, and mostly it is in the US, it's the US system that rewards innovation. So, many of the CEOs of large pharma companies, including, European, like, Pascal Soriot or Varas at Novartis have said, the European system needs really to rethink itself in order to adopt, innovation in the long term, because the risk, if we don't do that, you're going to have the haves and the have-nots.
Yeah, and I mean, if the market rewards less innovation as well, means in a way less returns, means less investors.
Exactly.
Yeah. No. I guess it's a society choice. I mean,
these are again they are complicated. They are complicated issues, but our role, at least as a leader in the industry, is just to give the heads up that there are consequences to what public politicians do, and we again we are here also to try to find solutions. But there is, they need to reward the people who take risks, right? Because it's a very hard industry. It's very hard to develop drugs. A lot of them fail, and so the few that are making it to the finish line, should be rewarded.
Yeah, I mean, I guess it's a very complex decision, even on the political level. But I feel like it's not really, let's say, improving. At least I've seen in France or even in Germany that a lot of even innovative drugs are even withdrawn from certain markets in Europe, even though they're already approved for pricing and market access, and they're already in the US. But let's see how it evolves. Maybe more on the personal, your story. Like, so I'm curious if on both Corvidia, CinCor, even Abivax, was it already your plan to go in and, let's say, not flip, let's say, but like exit pretty early, or was it more like opportunity based, depending on what happened?
No, I think the fundamental of what we do is develop good drugs. So I am actually absolutely, I'm trying to preach that the best way actually to sell a company,
like a great product,
is to make a great product and to have and to believe it is a great product. You don't control, as CEO, you don't control what the big pharma is going to do. People will think it's easy to do a deal. This is one of the hardest things to do. So the only thing you have, with your tool, you control, is to develop a good drug and think long term. Think about, what this drug could be in 3 and 6 years. And then you need to rally everyone, including the investors, to support the program so that the drug needs to be well differentiated. Where I part of my criteria when I have looked at drugs is differentiation. You can't bring, drugs that are me toos of me toos and me toos. The system cannot. But I still am convinced that bringing something that makes a difference to patients and that doctors would like to prescribe, that's why we are in this business. So fundamentally, I'm sort of like a bit like a Warren Buffett type of person in the sense that you need to create things, that are tangible, that are going to help patients. And then whether you do a deal or not, this is to some extent secondary because it's a mean to consequence. It's a consequence. Yeah. And I refute, and I think, in my judgment, the best CEOs are this way. The people who want to make money quickly on technology, okay, if you're lucky, yes, you can make it and make maybe a huge amount of money. But this is really more the exception than the rule, and probably it is not good because what you do when you're too short-term oriented, you try to hide things or you don't develop the drug as well.
Yeah.
And ultimately, that's not good for patients. So, again, I think fundamentally, what we are here for, develop good drugs. Companies, are bought and are not sold. No one can tell. So I didn't come to say, okay, I'm going to sell, in 1 year. I had no idea. The only thing I know, you need to develop well drug. You need to do it with tempo and quality. And this is, the sort of the combination of the two, which is the hardest thing to do. And you can see CinCor, on one hand, we did wonderful. We still, blew up one study, but at the end of the day, we had a great outcome for
Wow. I like that. I like it a lot, actually. Actually, it's also a great transition to when I talked to Bami from Svino. She said the first time she met you, you gave her. She said he gave me faith in humanity, and which I thought was very nice compliment. I was waiting to meet you, but from what we discussed, I think I can see where it's coming. I like this, some very caring and focusing really on the patient and the problem to solve.
Yes.
And then the rest
will
follow. And
exactly. And then probably because maybe I'm not smart enough to do the other way around. No, but I think fundamentally that's why we are for. And that's, when you are building a company, you're attracting people who want to have a mission. Yes, money is obviously important. Everyone wants to make money for sure. But at the end of the day, if you don't do anything meaningful when you come every day to the office, what is your, what's your role? So I think this is where, it's a kind of a passion, and you need to do like that. And some people do, some don't. But
I don't think. Yeah, I don't think it's. A lot of people in the industry do, especially I would say in the biotech industry, maybe more than in some big pharma, where it tends to be maybe a bit more diluted, at least from my experience. But not all big pharma are like this. There are a lot of people who care also in big pharma. Yeah. But I'm curious on your side, maybe if you can zoom out even, let's say, where did it originated? Is it something that you had from very young, or you cultivated, or some experience you were confronted to that?
I think it's probably hard to say. I think it's partly you see when you are, I was raised on a farm, and I was raised, in a sort of in an environment where things were, sort of difficult. So I think what you learn is, life is not simple, and everything you do, it takes time to do things. But I think the probably the generosity comes more from, I think, from my mother, who was a very kind person and tried to help actually poor people. So maybe a bit of a few genes from that. But I think honestly, it's a bit the luck of, if you ask me whether I would be in this position 40 years ago, I would have said never, even 20 years ago. So, life takes turns. I think the importance also of meeting key people who are, who help you grow in your career. That's also what I say when you're looking for a new job. Think about, the manager. To me, the company is one thing. The other is the job, is the manager you have. Because the manager can help you grow, or can destroy you, or can make you indifferent. But so you develop this kind of skills because you get inspired. You see some people who are very, charismatic or doing things. And by the way, this principle of do the right thing and then money will come. This was, the first time I heard that was was the CEO of American Express. He was in Paris. He attended his conference. And Amex became, one of the most successful company at the time, again, 40 years ago. And he said, always, don't think about money. Think as an executive, think about building something tangible.
Just funny for a financial company, right?
Yeah. But he did a remarkable.
It's even more important.
But look at some people who have done remarkably well. Like, again, look at Warren Buffett. I think you need to have a mission. You need to have something in which you believe. And then, the luck of life is that sometimes you meet some people who are going to encourage you and give you this thing. So,
and I mean, I like that as well. That's a precondition from your family, from your origins, and then also connecting to the right people. But I guess this precondition also led you to admire or to work with the people and going through. I mean, you went through, let's say, bigger pharma or big biotech at Amgen and then Ipsen, and you still have this like deep care and mission, which is and it's amazing. Maybe as a last question, still on the personal. Actually, I know your son. After you, actually, I didn't mention it when he was running co-founding a biotech in Boston, and he's also a co-founder. So we talked once. But I'm curious with such a intense career and high level position in between two continents, how did you balance, let's say, more personal life, and how do you approach it?
I think it's also part of luck. Is lucky to meet a wonderful wife who's been very understanding with the pace of my career. But also, what I think you can only be successful in your professional career, I think, if you have also some balance, outside. So some people take that in different ways and do sports, they do other things. But I think at least in the long term, I think personally having a family, a strong foundation of having kids, always again brings you back to reality. Because when you come home, who cares whether you're a CEO or not? You still have to do certain things. You still have to cook sometimes. You still have to do. And that gives you again this balance that I think is essential. So, yes, I've been again lucky at home. I had a good person who was with me and who was very understanding and who helped me also. Tells me also sometimes what I do wrong and what I should do more. But you need the balance. You need to do things, to relax as well. Yeah. The intensity of the big danger, especially when you're on CEO job, is importance versus urgency. You always get the burning fires every day when you come in the office. There is always one issue and something pops up. But as CEO, you're paid not only to resolve the urgencies, but really fundamentally to shake the future and to alter the course of the company you're running. And this can only be done if at times you step back you get out of this crazy world and you think, what do I need to make with the team, to change the course and to make really a difference in what you do as a company. So it requires a bit of discipline, but it's important, like on the weekend to relax, try to avoid to watch, all the time, your iPhone, because the pressure is constant, but stepping back.
I like that. I share it as well. For running a company, I can second this as well. Yeah, it was great. I think, it was great talking to you. I think it was actually the first time you're on the English podcast, or at least in the recent years, or at least talking with Abivax, which I think is great as well for the audience. I've seen you were on French TV or French, but I think for all the audience, at least in Europe and the US who don't speak French, I think it's great. So thanks a lot for joining again.
Thanks, man.
Yeah, and good luck for everything.
Thank you. All right.
Thanks for listening to the end. I really enjoyed the conversation with Marc. It was super inspiring, especially how his mindset behind all these like exits, IPOs, how he focused on the core product on the long term and how everything else follows. If you enjoyed the conversation, please hit the like, follow button, or even leave a review if you're on Spotify or Apple Podcast. Any of these actions would help us a lot. And I would be also curious to hear what you think. So please leave it in the comments below of this post, or send me an email to Philip@Flot.bio. Right, that's it for now. Catch you in the next episode.